Okay, good morning, everybody, and thank you so much for coming. It's lovely to see so many people here. We're going to have sort of the main introductions and the main notices for the main meeting at 11 o'clock. But for now, what we've tried to do in this initial session is to have sort of an introduction to what PPA is. And so I'm going to introduce you to my friend and colleague, Dr. Jeremy Johnson, who's going to take us through exactly that, through exactly what PPA is, and he'll be available to answer some questions as well. So over to you, Jeremy.
Thanks, Chris. Welcome, everyone. For some of you might have been before, many people this might be their first meeting. And really the purpose of this is to give a little overview of PPA, try and explain some of the features of PPA, and just give a sense of what it is, what it means, and there'll be opportunity to ask questions. So if you have questions, please do ask. Try keep them till the end if you can, but if you must ask it, just put your hand up, no problem. So, primary progressive aphasia. So, PPA really is an umbrella term and is not specific to any one thing. And if we break it down, the aphasia bit is basically Greek, and it means, this is a dictionary definition, it means an inability or impaired ability to understand or produce speech as a result of brain damage. So that's a basic sense of what aphasia means. Something that's lacking in this description is the fact that it's not just confined to speech, but it's anything linguistic, so that could be reading and writing as well. So what's primary, what's progressive? The primary bit talks about the fact that language is the key component. It's the leading feature of the PPA syndromes. It's an acquired brain disorder, so it's not something that happens as a result of a traumatic brain injury, that happens as a result of an infection or some other driving feature. As I said, reading and writing may also be impaired. And the progressive bit really alludes to the fact that it starts in a focal part of the brain, in some sort of language-involved part of the brain. But it does progress. So over time, it will move and involve other linguistic areas first, because they're closely related to each other. But over time, it will involve other brain regions, which is why the syndromes change over time. What can be very confusing, even for the doctors who are dealing with this, is the various names that you will hear given to it. So you might hear things like semantic variant PPA, logopenic aphasia, frontotemporal dementia, language variant Alzheimer's disease. And they all come under the umbrella of primary progressive aphasia, because hopefully what will be apparent from what I said earlier is that the unifying feature of all of these is that language is the key problem at the start, and that it is progressive and not caused by some other secondary phenomenon. And these various names like semantic variant, logopenic, language variant, Alzheimer's disease are all descriptive terms. They are not diagnoses themselves. They just describe the features that people see in front of them. All right? So what causes PPA? I mean, something has to cause it. The unifying feature of these diseases appears to be the accumulation of proteins in the brain. Now, your body is made up of a huge number of proteins, and a large amount of the physical structure of your body is protein. But for reasons that are not well understood yet, a change occurs, which means that the proteins are altered slightly, and they're altered in a way that makes them resistant to degradation. So you would normally clean out protein products, protein breakdown, clear them out of the brain, and recycle them. And for reasons, as I said, that are not entirely clear what makes this event happen, but changes in the structure of the protein means that it becomes resistant to degradation. And you can imagine, a bit like limescale building up in a pipe, once enough of this protein product builds up, it starts to cause damage. It has a toxic effect on neurons, and eventually that will cause neurons, which are the nerve cells in the brain, to die. And what's also become clear over the last 20, 30 years is that each of the different diseases tends to have a specific protein that undergoes this abnormal change. So this is just a brain map. This is looking at the brain from the side. You imagine you're looking through the ear, which would be somewhere around this level. And we've got several major parts of the brain. You've got this bit is the temporal lobe, which is next to the ear. It plays a large role in language processing. We've got this bit that connects the two, which is the temporo, because of the temporal lobe, and the parieto, because of the parietal lobe junction, because that's simply what it is. It's just a descriptive term. And then we've got the frontal lobe, which is at the front. The reason why I put that up is to say that depending on which part of the brain you affect, you get different effects that you see in the person in front of you. So the first bit is to say the frontal lobe over here is the area which tends to be affected when somebody develops non-fluent primary progressive aphasia. That's characterized by several features, but the main components are grammar and motor programming of speech. And that's because that's where those functions are stored in the brain, in the frontal lobe. The temporal lobe does other things. It stores a lot of your memory of the world, memory for objects, understanding what a table is, what a car is, what the noun happiness means. And that is the area that tends to go with semantic variant, primary progressive aphasia. And finally, the third variant that we see, logopenic aphasia. Logopenic, again, is just Greek saying fewer words. Tends to occur when you have damage of the brain in this area here, which I call the temporoparietal junction. So just to go through each of the syndromes, just to give an idea of some of the features. Semantic knowledge is knowledge of facts. So as I said, it's things like what is a light bulb, what is a clock, what is a table. The sort of facts that you don't know when you learnt them, but once you've learnt them, you always know them. But they don't exist at any specific point in time, unlike a memory of when you went to the beach with your family or when you got married, things like that. So early features are problems remembering names, problems understanding individual words. And later on, you might see features of not recognizing objects. So you say to someone, "Can you pass me the rake?" And somebody says, "What's a rake?" Even though it's in front of them. And it's not because they can't see it, it's because they've lost the meaning of what a rake is, so it becomes like a foreign language. It's fluent, meaning that people are able to speak fluently. Grammar is not affected, at least in the early stages. So they're able to repeat words and sentences, and they have no problems producing speech. But there can be some difficulties with reading, particularly in English, because English has a lot of irregular words, like, for example, the word chaos. If you don't know that it's pronounced chaos, then it should be pronounced chaos, and so people will read it as chaos. So other key features are loss of specialized knowledge, as we said. You can get something called numerical scaffolding. That's where numbers seem to be relatively less affected than words. And so people use numbers to build the structure of what they're saying. So they might refer a lot to things like we came from somewhere which is 40 kilometers away, and we left at 10:47, and we arrived at 11:35. And that's a way of structuring speech so that you can get from one point to the next. And we do know that people with semantic variant can complain of auditory symptoms, so tinnitus, ringing in the ears, also sometimes unusual auditory object knowledge, so hearing things and thinking it's created by something different from what it is, or sometimes developing a particular dislike of certain sounds or liking of other sounds. Then we move to the non-fluent variant. So in contrast to semantic PPA, the non-fluent variant is not fluent. It's characterized by halting speech that's effortful. The reasons for that is because a lot of the problem is due to the motor program of producing and articulating words in speech. So early signs will be difficulty using grammar. Grammar is also stored in the frontal lobes. You get this effortful, halting speech. Effortful not particularly because of word finding issues, but trying to actually produce physically the words. We can then also see problems understanding sentences, particularly of more unusual grammatic structure. But there's no problem understanding individual words, and there's no problem recognizing objects. So, converse to semantic dementia, the semantic system, the knowledge system of the world and objects, is preserved. So you can often find with progressive non-fluent patients that they might lose speech a long time before they lose understanding of speech. So speech output might go a long time before understanding of speech, understanding of objects and knowledge goes. There is an unusual phenomenon that's quite specific to non-fluent variant, which we call binary reversals. Binary just meaning it's either on, off, either yes or yes, no. So you have a phenomenon where people will say no when they mean yes, or yes when they mean no. They will often correct themselves, but it's quite a consistent feature in people who do develop it. And obviously, if you don't know that, it can be quite confusing when somebody says no, and then when you don't do it, and then they're sort of prodding you, saying, what are you doing? We do find that there's probably an excess of people who had childhood stammers or childhood speech developmental difficulties, which we don't understand yet whether that is required to develop this specific syndrome, whether it has a priming effect, or whether or not it just means that it's quite a vulnerable part of the brain's networks already, and so it's something that tends to struggle early. And I talked about the difficulty producing speech because it is related to motor output, so the brain's signal saying, I want you to create this sound, sh or p, and having to tell the mouth and lips and tongue how to move. You can see problems using the muscles in the face, so you can actually see the struggle to try and form words, but also with things like eating can be difficult sometimes. And lastly, of the three syndromes, we have the logopenic variant. As I said, in Greek, logopenic means a paucity of words or fewer words. And really the early features of it are single word loss, so a shrinking vocabulary, loss of the lexicon that people use gets smaller. They might have problems remembering words, but they also have difficulty reproducing sentences. And that's most likely because this syndrome does affect memory as an early component. So if you want to string together a group of words in a sentence, then sentence repetition becomes difficult. And actually that's usually one of the earliest key features when we are assessing people with logopenic variant aphasia, is to get them to do sentence repetition and see how they cope. There can be mixing up parts of words, and sometimes bits of words can be mispronounced, but grammar is usually not a problem. Understanding of individual words is usually not a problem, and production of speech in terms of the actual speech output again is fluent, so there aren't difficulties with producing speech. I already mentioned that some of the features of logopenic aphasia are related to memory, so it's not uncommon that we see memory problems as well. And actually the commonest underlying cause of this syndrome is the same proteins that cause Alzheimer's disease. So this is sometimes called language variant Alzheimer's disease. There are potentially some subsyndromes, although this is slightly contentious. But logopenic aphasia can be quite variable in how it presents, and sometimes takes a bit of time to be sure that that is the diagnosis. And there can be some made-up words. So we have seen instances where people will replace the meaning of a word with a different one. So for example, this is a real-life example of somebody who used the word kilb to mean a rabbit. And it's not entirely clear why that should happen, but some of it might be to do with actually being able to use the compartments of speech, of words I should say, so phonemes are the individual little bits of speech, and putting them together. We know that logopenic variant does cause problems with that, so that might be partly why this phenomenon happens, but we don't know exactly why it happens. So that's the end of my talk. If there are any burning questions now, please do ask, and I will try and answer them.
You said the deficiency of proteins. The proteins is produced by the red meat. But nowadays it's a no, you cannot have red meat. So how can you produce proteins without red meat?
Yes. So if anyone who didn't hear, the question was if there's a lack of protein in the brain, and protein comes from sources like red meat, then why are we being told not to eat things like red meat for health reasons? So I think just a few points to say is, rather than a lack of protein in the brain, the issue here is that the protein that exists gets changed, and then it has a knock-on effect that changes proteins around it, that makes it resistant to degradation. And the other thing to say is that in terms of the health side of things with protein, is that it is important to have protein in the diet. There are non-meat sources of protein, but I think it would be useful just to say that as far as we know, there are no specific diets that you should or shouldn't be on that clearly make any real impact on these syndromes. You've got a microphone, yeah.
Thank you. What is the evidence so far in terms of what might cause this? Is it a genetic problem? Or is it, as you say, the food we eat? Or is it exercise? Your research is pointing you in lots and lots of different directions, I'm sure. But have you got any clue as to where this is leading and what might be in the future the way of combating this type of dementia?
Yeah, so lots of things to try and answer in there, but I think to give a broad answer, it's slightly hand-wavy, I apologise, but that's because we don't know all the details yet. I think that the vast majority of dementia as a whole even beyond the PPA syndromes, and they are definitely similar, is not caused by genetics in the way that most people understand genetics, i.e. dad had something, I got it from dad, now I get it. Which is the case in, say, Huntington's disease, but most dementia is not the case, and the PPA syndromes are the same. There may be subtle variations in people's genetic structure that slightly increase your risk, but in that instance, it is definitely a combination of the genes and the environment that they're in. Like most things in medicine, we may find in the future that there are some things that slightly increase risk, like how much air pollution you're exposed to, whether you smoke, how much exercise you do. But I suspect that they will be very minor things, and that unfortunately the main feature of these syndromes is a random event that, for reasons that are not yet clear, the body of humans is, or the brain of humans is susceptible to, because there are a large number of protein misfolding diseases, which suggests that that is something that the way we are built, all of us globally, means that we are susceptible to this sort of thing. So it may be that you need a little bit of genes in the right environment and a bad luck hit in the right place at the right time, and that's what triggers it off.
I just say thank you very much, and as somebody who's been diagnosed only 3 years ago, I'm ever so grateful that, you know, this work is going on, and delighted to be able to take part and help in any way I can. So thank you very much. Thank you.
Well, thank you, and thank you and everyone who has taken part and does take part, because we need your help as much as anything to be able to try and solve these problems. Yes, sir.
My question is about the types of protein that relate to various dementias.
Mm-hmm.
I understand that the protein Tor, that's how I pronounced it.
Yes.
Years ago when I learned Greek.
Yes.
Is responsible for PPA, but I don't know if that's common across the dementias. I suspect it's not.
Well, very good question, thank you. So just to, in case for anyone who wasn't quite clear, the question is about a particular protein which is probably supposed to be pronounced Tor, but has been anglicised to be pronounced Tau, that is found in PPA syndromes. And actually, it's found across many syndromes. So there is a type of Tau that you see in Alzheimer's disease, you see it in genetic Alzheimer's disease, you see it across PPA syndromes. There are variations of it, though, and I think something that makes it complicated for us is that even if you took a single protein like Tau and said, that's the problem, actually there are multiple different forms of Tau in different ratios in everyone's brain, and how they interact and why you have all these different little forms, isoforms we call them, that all look very similar but they're not quite the same, is not very clear. But presumably the Tau protein is quite susceptible to this issue. The last thing I would just say is that the reason we find it elevated in a lot of diseases is because it is part of the neuron structure in general. It's a fundamental building block of all neurons. So it's probably, in part, we see it a lot just because it's everywhere, so it gets affected. Okay, yes. Sorry, there's a microphone, yeah.
I just wanted to ask, I've understood obviously that everyone with this condition, it kind of, as time goes on, it progresses differently. but I've understood that you can develop signs from different types of PPA. Is that correct?
Yes, absolutely. It's a very good question. So, whilst in the beginning, and whilst for the really classical forms of each of these syndromes, excuse me, the picture is nicely distinctive as I described it, it really isn't that uncommon that either people present with a syndrome that sort of has features of two, maybe even three syndromes that are quite difficult to tease apart. And it's certainly true that as things progress and you move from, say, a very specific part of that semantic network in the left side of the brain round into more frontal parts of the brain and deeper parts under the brain, you will start to see things like memory arrive, maybe behavioral change, maybe difficulty with grammar, and they all look more and more like each other the further you get into them. So they do change over time. Okay.
So I think we'll stop there. So can we just all thank Jeremy very, very much for the introductions. Thanks, Jeremy. So we've got a short break now. So we're expecting around 100 people today, actually. So there'll be more people joining us over the next half hour or so. So do help yourself to tea, coffee, plenty of water because it's so hot outside, and then we'll reconvene.
Thank you very much, Chris. So this is a Q&A session, so fire away. Sir.
Anne's had hearing loss. Anne's had hearing loss. It's been identified as fluid behind the ear, so it isn't related, but is hearing loss occasionally or regularly related to PPA?
So I'm going to just first of all reassure everybody that you were not planted in this audience to ask that question, because this is one of our main hobby horses. In fact, one of Chris's main research issues he's trying to address. So hearing is a very big and neglected topic in PPA. I could spend the next hour literally talking to you about hearing PPA. The kind of sort of York Notes version is that anybody with a hearing problem who's experiencing hearing symptoms, should say, with PPA should be being assessed. Their hearing should be being assessed. So, you know, we don't want that just to be put down to old age or, you know, oh, well, they've probably got a bit of wax or, you know, because sometimes there are things that can be easily treated. And so there have been, you know, hearing in dementia is very big news at the moment. I don't know if anybody, I don't know, people, it's always dangerous to ask for a show of hands, but has anybody in the audience heard anything in the media about hearing in dementia? So has it reached the thresholds? Yeah, it's beginning to get out there. But so far, of course, mainly people talk about hearing in Alzheimer's disease, but at least it's a good start because people are starting to pay attention to hearing and ask questions about why it is, as it seems to be, that people with hearing impairment of any kind, really, or unspecified, have an accelerated risk of dementia. Now, in the case of PPA, and with anybody with a hearing problem, the first priority is to try and make sure there's nothing easily fixable. So that would be things like earwax. And actually, it's been shown that even just treating people's earwax can improve cognitive function. As a study, I think it was a Japanese study. So very, very simple things. Slightly more complex than that is the situation where somebody, and this is also more common in older age, of course, has hearing loss for some other reason, but it's actually a problem with the nerves to their ears. So, for example, they may have had occupational exposure, and particularly cohorts of people that are now, reaching their 60s, 70s, sometimes did not have the sort of occupational awareness. And, sometimes it's also in areas that you wouldn't necessarily expect. So musicians, for example, routinely have hearing loss. And these are not rockers that have been standing next to megawatt amps. These are orchestral musicians of any ilk. So, there's a big occupational issue with sort of hearing loss, sort of that sort of hearing loss. And that can be sometimes addressed with hearing aids. And so that's really the reason for wanting to send people to the GP and send people off to get their actual hearing, what we call the audiogram, measured. But unfortunately, and this is particularly the case with PPA, once we look at the easily treatable things, relatively easy treatable things, we're left with a sort of a hearing problem which is not in the ears, it's in the brain. And that is a big, complex and very difficult to treat issue. And the types of hearing problems that people get in PPA, this depends on the type of PPA. People with, some of you may well recognise some of these things if you've been touched by this particular type of PPA, but people with semantic dementia, for example, quite commonly have altered emotional reactions to sounds, or they may have trouble identifying what sounds actually are. People with logopenic aphasia, which is often a form of, as I guess some of you will know, a form of Alzheimer's disease. These people, we're still getting information about it, but these people tend to get problems with making sense of complex environments. So, for example, if they're in a situation, we talk about an auditory scene, and that's nothing special. That's what happens all the time. So if you're in a kind of a pub, or you're on the street, or even sitting in a room like this one, almost invariably there's background noise, and there's a more or less interesting target sound you're trying to either identify, maybe you're trying to block it out. But it kind of is something that you need to be able to process. The brain needs to be able to process different types of sounds as they're coming in and stream them out. And that's a brain issue. The ears don't do that, the brain does that. And people with logopenic aphasia seem to have particular trouble with that. And people with non-fluent aphasia, and so Chris has just published a major study of this, showing that they get very, very basic problems with their hearing, right down to and including the issues of actually identifying when sounds are there or not. And really very simple types of sounds can be things that they would fail to pick up on. And that might, for example, be the nuances of speech, but it might also be things like, not necessarily what someone is saying, but accents. For example, if someone speaks in an unfamiliar accent, it can be completely thrown with that sort of problem. Or maybe they would fail to get the emotional tone of someone's voice, so to just not get that signal as to what they're trying to say. If someone's being sarcastic, they may not pick up on that. And this is, these are really quite basic things we take for granted, but of course, in terms of what happens in the brain, they're really complicated problems. And so the reason that PPA gets these problems, and to some extent the reason we think that people with Alzheimer's disease get these problems, is because the hearing areas of the brain are the ones that are targeted by dementia. I mean, it does target other areas, but the pathological process, and I get you would have heard from Jeremy this morning, some of you in the introductory talk, the brain networks that are affected are also the same ones that do hearing, the sort of the auditory brain. So that's the kind of, I've gone on for longer than perhaps I should have, but that is a very simplified kind of answer to that question. So yes, people with PPA get often very significant problems with their hearing. It's not well recognised. It's not in the criteria, the things that we talk about when we diagnose PPA yet. We'd like to change that. And there's limited awareness of it by medics, by audiologists, by psychologists at the moment, which again is a situation we want to change. But anybody with hearing symptoms should certainly be taken along initially to their GP and then take things from there. Okay. Yes. Eyesight is also a big and tricky topic. It also depends to some extent on what the type of problem is with the eyesight. So, for example, again, thinking about PPA, people with semantic dementia, one of the core features of that syndrome is an inability to recognise things by sight. So we usually think of it as being a language problem, which it usually is initially, but people will almost invariably, as the disease goes along, get problems with knowing what to do with objects by sight. So, for example, they may pick up an object and try and use it in a completely inappropriate way. So that's a kind of a recognition. It's you know, they're getting the signal in okay, but they can't kind of make sense of it. People with, I'd say, probably in my clinical experience, I haven't really studied it in research, but people with non-fluent aphasia tend to be, as a generalisation, relatively okay. And there may be other issues. So, for example, they may have another problem with their sight, like a cataract or something, and they may be difficulty expressing what's happening. So that is something that we do need to be alert to. But the visual area of the brain is usually relatively spared in that syndrome. But in logopenic aphasia, people can get the same sorts of problems again that Alzheimer's people get, which can be a problem, particularly making sense again of more complicated visual scenes, and particularly if, for example, they're being called upon to look at objects where there might be movement in space, or there might be different objects overlaid on one another, which is often the case, of course, in everyday life, or if they're seeing something from an unusual view, making sense of what that is. So there can be problems with vision, but it's usually later. So I guess what I'd say, the contrast with hearing is that we think, and this may be partly research bias, but we think also from our clinical experience, that the hearing symptoms are there quite early on. The visual symptoms tend to be later in the course of the illness, if they occur. Yes.
Can I just follow on from that? Can you hear me?
Sorry.
Can I just follow on from that? Because if you've got somebody with non-fluent of PPA, there's a problem with testing the eyesight. I have no idea whether the patient I look after can see or not. If I offer him some glasses, he puts them on, and so he puts on reading glasses and then wears them while he's looking at TV, which is some way away, so presumably doesn't need them. I don't know, because you can't do an eye test with him because he won't say the letters.
Yeah, so that gets back to the point about it's a problem of people expressing what's going on, but it isn't a primary brain problem there. It'll be an eye problem, but then because of the brain problem, someone can't express perhaps what's happening. So the end result might be similar, but I'm just trying to draw a distinction between sort of what's a core feature of the illness and what's a problem of communication. Because problems with communication affect all sorts of functions, of course, apart from vision. Sorry.
Going back to hearing, you mentioned about a change in hearing. So do you have any experience that you've seen or witnessed that where someone who already has a hearing loss, are they more likely to be susceptible to PPA? Yeah,
well, that's a difficult question. So people with a hearing loss are more likely to get hearing symptoms and are more likely to have a problem with their hearing that, it can be more difficult to treat if it sort of compounds something that was already there. And that's a big issue, and we recognise that for all types of dementia, actually. The issue of whether it might in some way provoke the illness, that's a much more difficult one. And I don't think, the honest answer would be I don't think we have any evidence for that at the moment. There's a lot of interest, not so much at the moment in PPA, but in Alzheimer's disease, in trying to actually, usually using, for example, animals, to try and see whether hearing loss really does cause, because, if you induce hearing loss in a mouse, for example, does that cause a problem with degeneration of the brain? And there is some early evidence that it might be the case in some situations that can occur. But I think all we can say at the moment is it's a very complex interaction between those two things. And I don't want people to kind of leave sort of thinking, my God, I've hard of hearing, I'm going to get PPA. It's not, we don't have that kind of evidence yet.
Just to say thank you so much that this organisation exists. I think we all feel very grateful. I have two questions. First one, and this is the first time I've been here. First question is, what is the future for me going to look like with semantic dementia? At what stage am I going to have to give up driving? At what stage am I going to need a carer? And no one has ever kind of come up to me and said, this is what the next 10, 20 years look like. I'm looking around today and I see there's lots of people in their 50s, 60s, not many in their 80s, 90s. Does that mean that people with semantic dementia die a lot earlier? That was my first question. My second question is about coping mechanisms. And I've developed things independently just because of my memory loss. For example, not being able to drive and use maps the way I could in the past, having to use Google Maps frequently to get to places. For example, putting in my living room on the wall a map of the world so that I know where places are, which in the past I would have known automatically. Now, when we've got all these coping mechanisms, maybe there's a process by which we could share them and learn from each other. So, thank you.
Yeah. So yes, so thank you very much. First thing to say is that this organisation only exists because of you, and all of you. And so, you know, I think you should all be giving yourselves a mental round of applause, maybe a physical one, because it's important that we acknowledge that, right? Always, I think, because, you know, I can remember when it started from a very tiny nucleus, and the only reason it's been possible, there are hard workers around the traps here, but the only reason really it's been possible is because of all of you. So the questions, they're big and complicated questions. So even if I was sitting with you in clinic, my answer to this question will be the same as the one I'm going to give you, to the first question, which is the reason that we don't, or neurologists don't tell you what's going to happen in 2 years, 5 years, 10 years, is not because they're being evasive or trying to protect you, it's because we don't know. So we know in very, very general terms about what happens in groups of people with somatic dementia. And, you know, we know that there's an earlier type of symptom and then there's some later symptoms and so on. But what you, I guess, are saying or asking me, and what I guess probably most people, certainly I would want to know, is what is going to happen to me. So I'm sitting here, where am I in this illness? Where am I going to be in 2 years? I'm doing this job. When we'll have to stop that? Those sorts of questions we do not know. And we are trying to fix that situation. So Chris may well talk to some of you about this. We've got a large study. It started already, so surveys have been kind of partly analysed. Again, thanks to all of you and people out there who are watching from home and others. We're starting to gather just that information, what we call staging. So we need to be able to be, really quite precise, if we can be, but for that we need more information. And I think if we can get that study done, that will be certainly that will make me one of the studies that I will be most pleased about. I think it will be one of the most useful studies we will ever do if we can get that done. Because I think, yes, we try and address lots of science and lots of things, but at the end of the day, one of the things that at the moment is the biggest yawning gap in our clinical care of people with PPA is our very, very poor ability to give prognostic information. Now, the second question about the coping. Now, this is individual, but you're quite right. And in fact, this is a really outstanding resource for sharing coping mechanisms. And so Nikki, I know in particular, is very, very keen to try and make this slightly more formalised and to get more detail about what it is that allows people to cope with illness and continue to lead some sort of a reasonable adjustment in their lives to the illness, and also what actually makes life worth living. Because I think one of the things, and this is a really big theme that's starting with, we're trying to push it, and I think it's starting to come out in the field, which is it's not really good enough to focus just on what people can't do. So a lot of what is really almost all of what has happened so far in dementia research has been about deficits. Earliest deficit, what can we say? Can we say that person's going wrong? How can we measure that? And there's obvious reasons for that. And of course, there's a lot of concern and there's a lot of interest in picking up very, very early changes. But what we also need to have balancing that is what are the things that are going on that can still be salvaged, and not just, in terms of coping, as you're talking about, in terms of people adjusting to the illness, but also things that could potentially be retrained and used by treatments. Because, if we manage, as we are all very much hoping we will, to get effective treatments for dementias, and they'll probably come in fits and starts. It won't just be one treatment, all dementia, or one treatment, all PPA. But if we get a treatment for a particular sort of PPA, we will want to know in detail what it will be about a particular patient we might want to give that treatment to, that would allow us to predict whether they will respond to the treatment, whether the treatment is working, when we might have to try to make changes to that treatment. And we want to be able to do that quite quickly and not wait for changes on a brain MRI, wait for shrinkage of the brain to occur. So for all those reasons, we have to actually be able to measure what the brain uses when it copes with things. And, you might say, well, what does that mean? Well, that's things like, for example, the brain more or less automatically learns things. If you give it a particular sort of stimulus, it's not a passive organ at all. What it will do is it will kind of process that, and usually the normal kind of response is that it will change and adapt to that, and it will show evidence that it's modifying its responses according to that stimulus. So that sounds a bit technical. So what does that mean? So that means, for example, if you're listening to someone you can't quite make out what they're saying down a noisy telephone line, for example, over time, a normal person, if that goes on, that situation, will start to get better at it, and they'll use other information, like they might understand the topic of what the person's talking about. They may know the sound of their voice, but quite familiar to them. And they can use that to fill in the missing bits of the signal. So one of the most interesting things that Chris has been showing in his research is that people with PPA, to a greater or lesser extent, can do this. So there is some hope that actually the ability of the brain to cope and to adjust and to compensate for the illness is there. But we need to study it more, and we also, I agree, need to pool resources. And there's no reason why, at the level of everyday coping, we can't be doing that now, immediately, from a group like this one.
Thank you. When you talk about treatment, are you talking about medication or practical?
Both. So, and in fact, even within medication, different types. So one of the really important things, and this is a thing we say to our funders and our people that kind of, policy makers, is that you kind of want, it's a little bit like in some ways, it's a bit like the cancer care model. So we want personalised treatments, plans for people, ideally, not just blunderbuss, one drug, that's it, that's the treatment. It's very unlikely it would be like that. It needs to be much more nuanced than that. So there needs ideally to be, and there also needs to be research into things like, how do we modify the disease? Now that's the obvious one, because if we had a treatment that could miraculously reverse all the changes, well, then that would be ideal. That would solve all our problems, but that's really unlikely. So the next thing is, what if we had a treatment that slowed the disease or halted the disease in its tracks? And of course, we can also then think, what if we had one to prevent the disease? And that's another very, very big and interesting topic that we're very interested in. But say someone came along and they've already got the disease, and we have a treatment that modifies it. So that's disease-modifying treatments. In other words, it actually slows the disease right down. That still won't be the whole answer to their treatment. We will still need ways to help them manage the symptoms that they already have. At the moment, we don't have any other type of treatment except the symptom treatment. So it's very important we don't stop doing research in those treatments. And those treatments come in two main varieties. One is drugs, so, tablets. So, for example, particularly those of you that have experience of people with logopenic aphasia, you may know about this. The drugs that are used to treat Alzheimer's disease, things like donepezil, for example, or rivastigmine, memantine, are essentially symptom-controlling medications. They don't change the course of the disease, but they boost some of the function that's already in the brain, the transmitter function. But aside from the tablets, we want to be looking at non-tablet or non-pharmacological treatments, as the jargon goes. So these will be things like speech and language therapy, and Anna Faulkner, who some of you will know, that you people will meet in due course, who's going to be joining us. We're very excited about this as a speech and language therapist, specialist speech and language therapist interested in PPA, is particularly interested in developing the kind of strategies for retraining of speech and language processing. But that in itself is not or can't be the answer. It needs to be a combination approach. But so what I'm saying is you can't ideally really have one without the other. And I think even once we start to get much better at treatments, that will still be the same. That situation will still prevail.
Hi. As you mentioned, there is no treatment for this aphasia, those who are suffering. But what skill we should acquire to have a communicate with them? It's very difficult and it's very frustration for the person because she cannot or he cannot explain or not tell, and she get very frustration. But we must have some skill to communicate. What type of advice you will give us?
Yeah, so it does really need to be, personalised. So what we would need to do is sit down with you in clinic, or you should sit down with your neurologist and ask about that in detail for what is relevant to you and your loved one. But actually, just in very general terms, I'll answer the question. So, because it's an important question, the sorts of things. So, again, this really does depend. Even though we like to get people together, and PPA community often are battling with the same sorts of problems, no question, no matter what type of PPA you have. But the fact is, it's a very complex set of illnesses, and the PPA syndromes are quite different, and they have quite different challenges. And your question really highlights this. So, for example, people with semantic dementia, the problem is not usually at all producing the speech, but there is a problem with the actual vocabulary. And so that really, you can imagine, that's almost like if the vocabulary is going, you have to ask questions like, could we retrain that vocabulary in some way? Whereas at the other end of the spectrum, if you've got someone with non-fluent aphasia, and this, as you rightly say, is a very frustrating situation because people with that problem are usually very well aware that they have the problem, but they can't make themselves understood, they can't use speech properly. And so there, what we're trying to do is bypass the kind of the spoken channel as far as we can. So, for example, the sorts of things we would talk about in clinic, we'd look at their writing and their ability not just to write sort of with a stylus, but to actually use another device like a computer, an iPad or something like that, to allow them to sort of bypass the speech channel. Because usually with the non-fluent type of PPA, at least for a while, speech is very much the problem. It's the articulation, the getting out of the speech sounds, rather than the forming of the ideas and putting them down. So sometimes people do very well with other ways of bypassing the speech channel, and to some extent, particularly since often, as many of you will know, a person's general intellectual function is very well there with progressive non-fluent aphasia. So their ability to understand and work out strategies is often really good. So we can use that to help them work with us or with the speech and language therapist to come up with things like dictionaries and communication books and things that they can point to and say, they've got a series of phrases and they can select one. And so basically it's about trying to get past the channel that is the most difficult for them. There is interest in trying to retrain speech, but that is at the moment very laborious and often quite exhausting for people who have difficulty producing speech. And we see this even when we test people, even when we test their speech, get them to do tests involving production of speech. It's so tiring to produce speech if you can't easily produce speech, that sometimes the better strategy is to try and bypass that altogether. Now, unfortunately, we're often caught because there are also, unfortunately, in non-fluent aphasia, sometimes problems with a person's coordination, their ability to, for example, do complex gestures of the sort that you need to use an iPad or something like that. So that it does need to be individualised. So I'm not suggesting that it's a simple matter of just coming up with an alternative communication channel, but we'd need to work with the person and then work out if they had a problem with their gestures, then can they use books and can they use other things to try and help them get around it. So that's the sort of answer to your question. But actually, the treatment of the hearing is also relevant there, because what we've found is that if we don't treat the hearing input channel, people's speech can also be affected even more. So we try and help as much as we can. We try and help all the other things that might be relevant to their ability to speak.
There are clinics abroad offering stem cell treatment. Do you have any idea of what their level of success is?
So there's somewhere on YouTube, I think that my colleague John Rohr was asked that question. He gives a very vehement response, which I'd suggest you all look at. There is no evidence that stem cell treatment works. And it's actually scandalous, I'd go as far as to say, because there's a lot of claims made for it. and a lot of money changes hands with no evidence, no medical evidence that we would accept as good evidence. It's also potentially dangerous, apart from the financial implications. So I would strongly dissuade people. I understand the interest, but I would strongly dissuade people and families from going down that path. Sorry to say, yeah.
I wanted to ask a question about reading and writing. My handwriting is unrecognizable now, and reading is a problem.
Yes, well, yes. I mean, it can be affected, and even in the non-fluent type of PPA. I'd have to say it's difficult. I mean, there's no easy answer to that question, and if you start to lose writing, then that, of course, restricts what you can do. Sometimes people can, and again, need to talk to you separately about this, or in clinic about it, but sometimes people can still use keyboards and iPads and things, even if they can't form the letters. So it's worth thinking about that. With the reading, it depends a little bit what the issue is. If it, for example, if it's a problem with the kind of tracking of text, then sometimes audio books and things are helpful, you know, the sound-based books. But if it's the actual kind of just the understanding of the signal coming in, that is more difficult. And to try, and then we're sort of almost talking about, are there other things that stimulate the brain, that give people a lot of pleasure, which are not reading? And the one that we would usually plug, and it doesn't work for everybody, but it works for many people, is music. I'm not suggesting it's a substitute for books, but it's not a bad start.
Is there any evidence that electrotherapy could be used to reduce the loss of neuroplasticity with age and effectively rewire the brain?
Yeah, so this is a more difficult one, because there's different types of sort of stimulation that are being used, electrical, magnetic, and so on. And there have been some claims that it affects that and may improve that, even in PPA. It's not a very secure evidence base, but I think it's in the realm of, I'm not at all putting that in the same category as the stem cells. I think it's one of those areas where it needs more work. It also, one of the very interesting things I think about that sort of modulation therapy, which is like you stimulate the brain or you change its wiring function more than the structure, it's the way things are functioning, is that our own research suggests that because of this capacity for what we would call plasticity, which is really what I was talking about before, which is the brain's ability to adjust and cope, that it might be that if you use that type of therapy in combination with a tablet or in combination with something else, it may really come into its own. It's quite technically laborious at the moment and not that wide. You can imagine you need a lot of infrastructure to give it. But, you know, the other very interesting development, which, by the way, also cuts across hearing and other things, is there's an enormous interest at the moment in portable devices of all kinds that people can take out into the community, out into their houses. There's a lot of interest, for example, in sleep recorders and so on. So I think I'm hopeful that you know, the way technological change usually evolves, that whole landscape will be transformed. So it won't be necessary to be in a lab having that done. It may be possible to do things more remotely. But we're right on the cusp. So I don't think we've got a clear answer about that yet.
Sir, in an answer to a previous question, you used the word planned treatment. May I take up that word planned and ask you how, in my wife's case, PPA, that is provided, the planning, who monitors it, and how is it adjusted according to the process of time? Where do we get this planning from? We visit a neuropsychologist twice here at the hospital, the same person, and also one person comes to our house twice a year, much appreciated. But you use the word planned. I'm very interested to hear if you could develop that, please.
Okay, so I think so just thinking about what we would do in our clinic. I mean, I think we would, we do try and plan. So that really, I don't think it's very, we're not talking about anything very sort of highfalutin, really. I mean, this is kind of, for example, it depends a bit on the treatment. But for example, in in the case of the symptomatic drug treatments, we've got, I mean, I'm leaving aside clinical trials and research because that's hugely involved, and at the moment we haven't proven that things can be used for treatment. So that's putting aside that, of the standard treatments. So when you start someone on a tablet, for example, there are schedules that we follow. And for example, in our clinic, we have a protocol where they start the tablet, they come back to the nurse clinic that we have, then they have another schedule of visits back to the clinic. The GP takes over prescribing, we give them a follow-up phone call. And then the dose is adjusted based on sort of questions that we ask. In the case of non-pharmacological, so this is kind of, for example, if you had speech and language therapy or something of that kind, or some other intervention, and that might be something very simple like giving someone a device like an iPad or something like that to use. I guess the planning is in the stage of teaching them what they need to do, monitoring, are they able to comply with that, reviewing it sort of relatively frequently. So, depending on the type of treatment, you maybe every few months, that sort of thing. So those are really basic things. I mean, if we're talking in the realm of particularly what the sorts of things that a speech and language therapist might offer, that I would be on very thin ice to be sort of giving you specific answers about that, because I think it would depend on the, on the type of kind of, if they were using some form of cognitive rehabilitation, on the type of treatment that they were actually giving. So it might depend on the detail, in terms of the planning then might depend on the details. But we don't, I wouldn't want to give anyone the impression that we kind of try and approach management, I guess, willy-nilly. We always try and anticipate things where we can. And so one of the reasons for bringing people back to clinic when we see them in our clinic is, for example, so we can have be re-examining them neurologically and looking for things like the emergence of problems with their coordination or problems with their balance, those sorts of things, problems with their swallowing, so that we can actually plan things. And actually swallowing is a good example, because there's a very clear sequence of planning that has to go on about things like review of diet, review of nutrition. That often involves, we need to get help from experts like the dietitian or the speech and language therapist, measuring the person's swallowing, and then making a decision based on that about what type of diet they might need, reviewing their progress on that, and ultimately maybe even thinking about, do we need to try and bypass swallowing altogether? So those do, I think, need a lot of active discussion and planning. So those would be examples. Is that the sort of thing that you meant?
Is there any evidence?
Sorry.
Is there any evidence of a link with PPA and long-term use of something like antidepressants? And I'm talking 20 years.
There's no evidence. What's behind the question? Can I ask?
The person that we are supporting was had been on before she was diagnosed.
Right.
Had been taking non-stop antidepressants specifically Prozac, for 20 years.
Okay.
And I just wondered if there was any anecdotal evidence out there.
Yeah, I mean, there are not really sort of large or very good studies that have actually addressed that specific question. I don't think clinically that would be my impression, that there is a danger of that. I mean, one of the problems is, just talking very general terms, obviously I don't know your individual case, but you have to be very careful, because sometimes depression signals a neurodegenerative disease. And of course then, it can seem as if someone started on the antidepressant and then they got the problem. But I don't think there's any evidence at the moment that those types of drugs cause neurodegeneration. In fact, I'd say that you've got to be really careful about those sorts of inferences, because sometimes antidepressants are vitally important. And I mean, obviously there are drugs that get a very bad press in the news from time to time, right? Sometimes justifiably. So we have to be quite careful about to judge each one on its merits, I think.
Going back to symptoms, I work as a speech and language therapist with people who have PPA and also people who have aphasia caused by stroke. And I've noticed that in many people, people who have post-stroke aphasia seem to experience more frustration and a greater level of insight than people who have aphasia as part of PPA. And I wondered if you had any explanation for that. It does affect treatment and management, and whether anyone's doing any research in this area too.
Yeah, so there's a really big, important question behind, even broader question behind that, which is what are the differences and similarities between PPA and stroke aphasia altogether? And it's a massively important question. It's actually surprisingly difficult to do those studies, because what tends to happen is that people with PPA and people with stroke aphasia get siloed into particular clinics, and the research groups, they're often doing very active research, but they're not doing research that cuts across. And I'm afraid to say, I feel a little bit like that at UCL, that we would really like to do much more collaborative work with our colleagues. There's a very big stroke aphasia unit, a world-class one actually, but what we don't have at the moment, which I want to change, is an active collaboration with them. Because I think that will be the ultimate way to really try and answer your questions. Because it certainly is not the case that PPA is like slow motion stroke aphasia. I mean, there are very unique challenges of PPA that are not encountered by stroke aphasia, and vice versa. I mean, I suppose the very kind of just sort of simple responses to that question would be, well, there is a lot of frustration, of course, in things that happen very suddenly, and there's no chance for that person to compensate, and that's catastrophic. It's catastrophic to have PPA in many ways, but at least there's often a period of adjustment that can go on, and stroke aphasia is by definition not like that. There are also, of course, different trajectories, and this gets back to some of the things that have been raised. In that stroke aphasia, there's often some initial improvement which then stops, whereas at the moment we think of PPA as being something where there is not improvement during the course of the illness. So that's a fundamental difference with them, and that probably speaks to things like the plasticity, the compensation, the sorts of things we've been talking about. I also think it also depends a lot on the type of PPA, because and probably your practice, because I've seen people personally with non-fluent aphasia that have got profoundly depressed and frustrated, and sometimes have needed to be treated specifically for that because of their problem with speech. And I mean, as a neurologist, I've seen people with stroke aphasia, of course, and I would say it's every bit as severe. So I think it depends. It's certainly the case that some of the other types of PPA, where there might not be quite as much awareness of what the level of deficit. But that's also true, of course, in the stroke realm for things, so-called Wernicke's, so-called Broca's aphasias. They're very different responses usually to that illness from the person that's involved. So I think that's a really big, difficult topic. It needs more work. So? Yes, I do. But what we can't predict is, whether an individual person will reliably and at what point. It's usually quite late. But yes, there is a sense in which speech will disappear in some people. That can happen.
Because I can see with my wife, 4 years ago, she could speak. But now, it's
yes.
extremely difficult.
Yeah.
She can express.
Yes. Yeah. No, I think there is, unfortunately, that is something that we recognise. Yes. Sorry, I met someone over here.
It's okay. Can you hear me? Oh, you can now. Yeah, that's good. It's a very simple question. First of all, this is absolutely fantastic. It's the first we've seen of all this. But I don't know how many neurologists there are in this country. But when ours diagnosed what I had, he then went on a computer for 2 seconds to say, you need to go on this website and learn what it's all about. And that was it. So my lovely wife and I sat around for 5 or 6 weeks before we managed to come to this and actually learn a lot more fantastic about what is happening. So do neurologists talk to you, very simple, and are they being encouraged to actually talk to people after they tell them what the problem they've got?
Well, we spend a lot of time evangelising PPA to the wider neurological community and trying to win hearts and minds. It's a difficult one. I mean, there are not enough neurologists in this country by a long way, and a lot of general neurology clinics are terribly oversubscribed. So in my, I occasionally masquerade as a general neurologist, and in my other life, working in another place, completely remote from London, and the clinics there are very different to our cognitive clinic, and there is not enough time to see people properly, to what I would regard as properly. So I'm not excusing dismissive type of, well, you know, that you just need to go on a website, but I do understand why sometimes the pressures are so great on clinics. Really what is required with any complex problem in neurology, I mean, you know, there's very, very few simple neurological problems, but, you know, some are more complex than others, is enough time to take a proper history, examine the person, but more to the point, talk to them. Because, you know, it's not enough, is it, obviously, to tell someone you've got this life-changing illness, see you later or see you in 6 months. And what we try and do in the cognitive clinic is allow enough time that we can do the talking and we can, you know, tease things out, address some questions. We then have follow-ups. We have a very, very, very nice, it's a real luxury, fantastic nurse-led service that the specialist nurses, Katie and Frankie particularly at the clinical side, who can follow up with us and help us. But that is a real, I mean, in the NHS, that is a real luxury. And I mean, that is, you know, I think we hope we do deliver a good service, but it's not available many places. So I guess my answer is that I think we do need to win hearts and minds and boost awareness. We write things regularly. So Chris, for example, and I have written things for the wider neurological, wider medical community, because, you know, GPs need to be aware of these illnesses as well. In the hope that we will change that. I think it probably is changing. I mean, there was a time when dementia, and this is, when I say a time, I mean a time 2 or 3 decades ago. My colleague Martin Rosser, who's probably the real pioneer who changed this in this country, when he was a registrar, you know, he's a bright young registrar, he was told, so the story goes, why are you doing dementia? It's not even neurology. You know, that situation now would be unheard of. So, you know, you've got to kind of always look, there's like the top of the mountain, see how far we're going, but you've got to also look back into the valley and see how we've come. So I think we have come a long way. And I do think that, you know, a lot of neurologists now will at least have heard of PPA, they may have some idea of the different types and so on. But there's more work to be done. And I would always urge people to be referred to a specialist clinic. And it doesn't, like a tertiary, the next step up, specialist neurology, cognitive clinic. And it doesn't have to be UCL. You know, there are good, really good clinics in other parts of this country now. So, you know, I think I sympathise, but I also see it from the other side.
I'm sorry I came in a bit late, so I don't know if this has been covered anyway. But when I first got my diagnosis, I was told that I would be able to have some help because of my words, you know, I lose my words now. I live in Richmond Borough, and they're now saying that you can't have any help unless you're unable to swallow. Is that the same in other places? And if not, why not, I suppose, or can we do something? I am trying to do something with them to say that it's just not right. And it's going to be a lot better for me to be able to look at that for a long time.
Yeah, I mean, it's...
without that, you know, is there anything else that I might be able to do?
Yeah, it's not right. So, and it varies, and it does unfortunately vary in different parts of the country. And that's a fairly extreme, I'd say, position. And that gets back to a lack of resources. You know, we've got and then it gets back to much wider things. I promised myself I wasn't going to mention the government. But I was sort of given an entree about when we talked about government policy. I mean, I obviously hope we have a government tomorrow and all that. But it's kind of, you know, we kind of need more resource. And that comes across as tremendously unenlightened, unhelpful, ruthless, unsupportive, but it will be driven ultimately by resources and what people can offer, and it does vary from place to place, and that also is unjust. And you know, I don't know what I can say or realistically promise to try and do. All we can do, I think, is when the individual people that we see, try and go into bat for them, which we absolutely do. So to try and help them find solutions and workarounds, and sometimes persistence is rewarded. But of course, it shouldn't have to be that way, that you've got to fight to get this stuff. But the squeaky door phenomenon is a real phenomenon, and sometimes you need to have help guidance, knowing what squeaks to make, because some are more effective than others. And, you know, there are certain things that will tick boxes, that will release things. But it's not at all an ideal situation, and I do sympathise with that.
We've done a sort of letter about me,
yeah.
And sending that off, and obviously not just for me, but for anybody else as well. So we'll try and see if actually just getting we thought maybe having a story about one person might make
and I mean we should
about it a bit.
Yes, and we should be lobbying MPs, and while we've got a parliament, you know, we should be lobbying it, because I mean it's kind of that's the sort of thing that they jolly well should be paying attention to.
Thank you.
Sorry.
On the same note, my dad was diagnosed in January with PPA, and nobody seems to be coordinating his care. So he's falling a lot, and the GP's now referring him to a falls clinic, but doesn't seem to be connecting that with what might be happening with his PPA. He also had an eye stroke, which that came just before the diagnosis. How does he go about referring to a more specialist clinic to get that coordination of?
Coordination is massively important. And actually, because it's such a complex illness, it's not always seen to be part of the same illness, which can be a real trap and a difficulty. But people are accessing lots of different services, like a falls clinic or a speech and language therapist. There's no one joining it up. I think the short answer is that referral to a tertiary clinic, a cognitive clinic. So a memory clinic is one thing, but even within the memory clinic world, there's a need for better education about this. And I would say, I mean, I'm being quite partisan, but my belief is that people with PPA deserve to see a cognitive neurologist who understands the illness, and that then really requires a referral to the relevant clinic from the NHS GP looking after that person. Yeah. Yes.
I don't know if you've literally just answered the question. You talked about a list of specialist clinics, and we're just wondering, how do we find out where they are, and how to be referred?
I think what we might do might be useful to take that away, and I'll talk to Chris and to Nikki about it, because I think it would be a useful resource. Rather than sort of trying to answer you off the top of your head, but you know, there are people in Manchester and Cambridge and Oxford, and you know, they're around, but they're not as many as we would like. But what I'll try and do is give some thought to that, so that we can answer that, so that's sort of more available for people, that because sometimes there are issues about referral pathways. And I'm not at all suggesting that everybody needs to come to London, and sometimes that's not feasible anyway for various reasons. Yeah. So.
I think it's me, is it? Maybe what I wanted to mention has just been spoken about, penultimate comment. But interestingly, I'm just now picking up on the neurology and the psychiatric side of things, because I actually think we're not belonging in this session, because my husband doesn't have PPA as I am hearing it, but it was his language that first took him to the GP. His loss of word memory, but nothing that I'd noticed. He noticed it. I didn't notice his loss of memory. But it was the volume of his speech. So that doesn't seem to be covered by PPA, and I don't know if I'm correct. I did discuss it before with the consultant. But I just wanted to point out that it wasn't the neurologist he was sent to. It was, of course, a memory clinic and then the psychiatrist. So we're from the Midlands, Birmingham, brilliantly looked after by the NHS, both neurology, because it's Lewy body dementia that he has, and psychiatric as well. But my mother had Alzheimer's for 20 years and looked after by us, and she was looked after by initially the psychiatrist, then it was left. We didn't need consultants any longer. But where does this all fit in? You're a neurologist looking after the speech. We actually see the psychiatrist for this cognitive thing. And does his actual lack of volume?
Yeah.
He's been complaining for years, I'm deaf. I say it's his speech. But
yeah. So we absolutely need our psychiatry colleagues. So I'm not dissing psychiatry. It needs to be a team effort because neurologists would not be able to manage the wider burden of dementia. Absolutely not. But I do think the very, very specialist situation of PPA is a slightly different situation. But we rely on a sort of symbiotic, hopefully very, very harmonious and nice working relationship with psychiatry. So I want that on record. We've had people like Liz Sampson talking here, for example, talking to the group. We've got very close colleagues in psychiatry. So I don't have any problem at all with psychiatrists managing the situation. But sometimes some neurological input can be very helpful. The interpretation of something like soft speech, for example, so to a neurologist, that says a problem with the basal ganglia of the brain that control automatic movements, including how you pitch your voice and how you do that. Now, Lewy body is a very specific, very big, and it's a specific illness, but it's a different big topic in its own right. But just in terms of the PPA, the more mainstream, what most people in the room will be thinking about with PPA, particularly with non-fluent PPA. So I'd encourage people that are interested to download Charlie Marshall, who's sadly moved to another part of London now to run his own clinic, but did a PhD with us very recently. Many of you will have met Charlie. Wrote a very nice review about PPA in the Journal of Neurology, which is freely available. And one of the things that we talk about in there is the wide variety of different presentations of particularly non-fluent PPA. And that includes, at one end of that spectrum, people who very much have a motor problem, so with their speech. For example, controlling intonation and controlling what we call prosody, the melody of speech, or volume and those sorts of things, right through to people that have word finding and those sorts of problems that we think of as more typical language. But it's speech and language. It's really that continuum, and that can be the motor aspect. This is an immensely complicated gesture, of course, to produce a speech sound, to time it correctly, to get the right emphasis where you want to put the emphasis, to get the right volume, the right pitch, and so on. But we have had people with PPA whose first symptom was, and they struggled to have other people take it seriously at first, unfortunately, was their inability to, their French accent went off the boil. They were bilingual, fluently bilingual, the lady I'm thinking about, and she suddenly discovered when she went to France, she couldn't speak like a native anymore. And that was it started with that. So it's a broad church, and it can start unquestionably with problems with control of the motor aspects of speech, PPA. We managed to wind up. Do you want to announce lunch?
So, yes. Thank you. So, can you just join me in thanking Professor Warren for his time today? Thank you. As I'm sure you can imagine, he's an extremely busy man, so it's really kind of him to give up his time. Lunch is now served, and we didn't want to go too late to lunch because that is a nice opportunity for you to meet other people. So look for people with the same kind of stickers as you. Lunch is through in that back room there, and we'll reconvene at 1 o'clock for our next session. Thank you.